All surgeons are gentle.
Well, I know, but it's not. It's routine for us or for the doctor. They see a lot of it, and for the patient, it's like this is the first time or second time. So
yeah, after in the beginning when you start treating them, it is hard. It is easy to lose that. I think once you've treated enough kidney stones, you realize that you got to do some education. You got to try to put yourself in their shoes a little bit in order to help them through this, because otherwise, kidney stones are horrible. And what's fascinating is that his kidney stone might have been tiny, and actually the people with really big stones often don't have a lot of symptoms because again they're not getting stuck because they can't get out of the kidney. Yeah. So you have all these. There is no one story for kidney stones. Mm-hmm. There's people have terrible pain. Sometimes it goes away. Sometimes it doesn't. Sometimes the pain then it goes away for 2 days and it comes back.
So why do you like to catch the stone? Just so you can examine it afterwards, see what it's made of?
Well, and I know that it came out. No. So I get both. I get one that I know that's out, so I don't have to. I'm very happy to get imaging because it tells me what's going on. I'm sure Dr. Moore loves it when my patients come to see him. But at the same time, if they pass it, then I know that the story's over. So, and then I can analyze it, tell them more information.
When they catch them, do they ever catch more than one at one time?
There are definitely people who pass more than one. And so the other part of passing it that's key that people need to know here is that the tube that comes down from the kidney is very thin. We talk about a 5 millimeter stone could pass. That tube isn't 5 millimeters wide or a quarter inch wide. It's 2 to 3 millimeters wide, and that's very small. And it has to widen to let and there's some choke points where these things tend to get stuck. And as they kind of make it through different ones, they can roll along and work. And some people can pass bigger stones than other people.
One point about the pain that I've come to recognize, you think that once somebody has an episode of pain associated with a stone or something else, the next time they have it, they expect it. It's easier. It's the other way around. It gets harder and harder.
Probably panic when they
feel they know it's coming up, and it just gets worse. So
yeah.
For me, it's when you just said that, it'd be the quintessential of slamming your finger in your car door or something, and then do it, then expecting to do it again. Like I wouldn't do that for the life. Yeah, it's kind of scary for people.
Yeah, but the other thing too is that sometimes it's different. One side they feel it one way, one side, you feel stones down by the bladder a little differently. I was talking about how you feel the pain up in the kidney, but that's not always how people feel it. So a lot of times people do still feel some pain down by the bladder or even down in the groin, lower in there.
Does it go from one kidney to the other, back and forth?
It shouldn't unless they're passing one on both sides.
I don't mean that. I mean from one episode to another episode.
People can pass them. Yeah, some people form them only in one kidney. Some people form them in both kidneys. That goes back to
diet and
all those other things of what somebody's risk factors are and how modifiable they are and all those kind of things.
Drinking water. Back to the water.
Got to get the water in.
Drinking water.
It's all about the water.
Doctor, I have a question. What are the symptoms of the onset of a kidney stone? What are those symptoms?
So the most common thing you'll hear people say is just out of the blue pain, especially in their mid-back on one of the sides, maybe out all the way on the side, the flank. That's probably the most common thing we hear. And then as the pain gets bad, nausea. They may pass some blood that they can visibly see in their urine. As the stone gets down lower, they'll feel like they have to pee a lot more, or they'll feel like they need to pee, but they're not peeing. That's what a lot of people tell me. Doc, I'm not peeing. I'm not peeing very much. I'm not peeing as much as I used to. I've heard this before. It gets my brain working.
Yeah. Well, there are different reasons why they don't pee, right? If they're men and
right, sure,
your age,
sure.
Yeah, but with the pain, we know it's a kidney stone.
It's
more or less. You can guess.
We can. Yeah, we do. I mean, there are other things we have to think about.
Right.
And
I was going to say that.
So a lot of the people. So if somebody calls my office and they're in pain, the first thing we have to gauge is how bad is the pain. If their pain is really severe, we want answers for them quickly. We want their pain to get controlled. That's when we send them to the emergency department.
So
that's what it's designed to do.
They don't get caught in the telephone system, do they? And help me,
please. I wish that yes, that wasn't the case.
So you get them. So when you have an emergency, you get them in pretty quick.
So if we can get them to the emergency department, if they're really in bad pain, nausea, they can't keep anything down. And that way we can also get some imaging quickly. Otherwise, we see them in the office. We'll get them on some pain pills and
get imaging.
And that's how we
What else could mask itself as a kidney stone in the beginning, thinking maybe that's what it is and it's not? What else do you find for people?
The most common thing would be just routine back pain that we see is, somebody who's had a kidney stone. We were talking about how this is something that immediately comes to their brain, but they tweak their back and they're just very worried that they're going to have another kidney stone.
See,
You could imagine that. So I'd say that's probably the most common one, but there are a lot of other things depending on the side. If it's sometimes when it's on the left side, we get every once in a while somebody will actually have something like a colon infection. There can be numerous things when they have more groin-based symptoms, which every once in a while happens and really confuses us. We could think more about urinary problems, prostate problems in men, urinary tract infections in women, especially when you're seeing blood, other things like that. Those are things that can be confusing.
yeah. So it's just not a simple kidney stone. You have to look for other things and rule out the kidney stone immediately, or rule it in.
Right, and so I love that Dr. Morris here. That's why the imaging is actually plays a pretty critical role, because it can give us a very definitive answer, depending on the type of imaging as well.
How do you decide on the treatment option? Decide depending on the size of the stone?
That's the biggest factor. And then the first thing we do is, if the stone is less than 5 millimeters and the patient's up for it, we usually try to give them a chance to pass it, not have any intervention from us. If it's bigger than 5 millimeters, we'll tell them, hey, this isn't real likely. If it's 5, 6, 7, we'll tell them, it might not be likely, but if you really want to give it a go. I've seen a patient pass a 1 centimeter stone, which is almost a half an inch stone. I've seen it.
Wow.
I've seen it.
Wow.
He handed it to me. And he's a big dude, and I know what he could. I watched him do it. I saw him a month later, and he handed me this stone. I was like, okay, impressive. But that is a very rare phenomenon that somebody can do that. So in that situation, it depends on how quickly we need to intervene. It's certainly a much nicer intervention to do the shockwave, because we don't do anything inside them. There's nothing put inside them. The recovery's very quickly as long as the stone fragments nicely and passes easily. On the other hand, sometimes people are in a lot of pain and they need a definitive procedure. We go in through their urinary tract with a scope. There's no incisions. It works very well, and especially unless the stone is really hard or there's a lot of bleeding or something else. Every once in a while there's infection, we have to delay things a little bit. But the problem there is the urinary and some of the post-operative stuff. There is some irritation, some annoyance afterwards from us being there. We have to leave a tube inside that we call a stent, which is irritating. It's all very temporary and makes a very painful problem go away.
So the stent is there to keep it open?
So to allow everything to heal up, from the stone being in there, from us being in there, from any blood clots, from us being in there. But if something's jammed in there, you take out the stone, it's still going to shut, and they're going to feel like they still have kidney stone pain. So we put a hollow tube in there, which we can remove in the office 5 to 7 days later.
Yeah, that's interesting.
It works well.
What do you think, Dr. Moore? Pretty interesting, huh?
It is interesting stuff. Yeah. And when there's difficulty getting into the ureter, the tube that goes from the kidney to the bladder, sometimes because of the anatomy, of pathology, you just can't do it, then Walter will call me.
That's exactly right. That's what we do.
And,
What do you do?
well, I'll...
Besides look, what do you do?
No. Looking is just the first part. Then what I'll do is I'll put a needle through the skin into the kidney.
Oh, really?
Into the dilated, yeah, because when the stone is impacted, the ureter and the kidney sort of balloon up, and that's when patients have pain. And I'll put a needle into that ballooned up kidney, into the collecting system, and then I'll pass it a wire and then a tube, and that tube will drain the urine directly from the kidney out of the body.
What do you think about that?
It
Dr.
decompresses
Parker?
everything so that we can then get to the stone.
Yeah.
And gives us multiple access points. We can then come in from the kidney with our scopes, the same scope that we'd use from the bladder end. We can then come in through the back. Or if there's an infection, this is also another great time.
It's a little team approach here.
Oh, absolutely. Yeah.
Would you do it together, or
Most of the time,
you're with them, or?
well, that is actually a way that we use to treat. So we talked about bigger kidney stones, so 2 centimeters and above, that we use the same process to access those stones. So in that situation, it often is a team approach. The radiologist comes in, talk about the anatomy, what's the best approach, what's going to give us the best angle to get to the stone with our rigid scopes, and then But otherwise, if it's needing access for other reasons, we usually turn the patients over to Dr. Moore for a short period of time, and they come back to us.
Cool. So getting a sign, we have 1 minute. I don't know what that means. Since Tony left,
I'm going to have to run.
I know you're going to have to leave. I got it. So, well, that's pretty interesting. Would you be willing to come back and talk on another topic down the future?
Whenever.
Well, there's another topic that men are interested in called Eurolift, which is,
Happy to.
we can talk about that. If you want, you can come back, Dr. Moore, and you can, we may need you as the radiologist too. Dr. Moore's going to stay anyhow. Dan, he's going to go to, when he gets ready to go to break, we'll do that. So this was pretty interesting, especially since both of you are here. That's kind of coincidental. I didn't plan it like that.
Lovely when he walked in.
Yeah. It was good. So we got to see the total team approach, more or less, people don't think about that. People don't think about that. Think about
Better
kidney
when that's
stone.
the way it works.
Where are we at, Dan?
Yeah, we can do break now.
We can do break?
Okay, absolutely.
Okay,
If you guys are ready.
Dr. Parker's going to leave. Dr. Parker, thank you for
Thank you
coming.
very much for having me.
We had a good time. We'll do it again. And Dr. Moore's going to stick around.
I'll stick around.
And Dr. Dentico is going to be coming on, I think.
Absolutely. He's actually online right now.
Oh, cool.
So as soon as we get back from break, we'll get it going again. Okay, and thank you. Thank you so much, Dr. Bruce Moore and Dr. Walter Parker, and especially Dr. Ed Alio for hosting. And this is WGHQ AM 920 and 92.5 FM, Kingston Community Radio. My name is Dan Gatis, and it is Monday, May 24th, 52 degrees here in Uptown Kingston, and a little weather and forecast for Kingston and the surrounding areas. Sun and clouds mixed today, a high of 71. Tonight, a few clouds, low 49. Tuesday, partly cloudy skies, a high of 77. And Tuesday night, partly cloudy, a low near 60. Wednesday, partly cloudy, a 40% chance of an afternoon shower or thunderstorm, and possible strong gusts of wind, a high of 86. We'll be right back after these messages.
Starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for starting your day with
Your old fridge or freezer has served you well for many years and through many summer holidays and barbecues. But now, it's an inefficient energy hog running up your electric bill. Cash in on Memorial Day appliance sales and upgrade to an Energy Star certified model. Central Hudson will pick up your old refrigerator or freezer, recycle it, and pay you $100. To schedule a pickup, visit centralhudson.com/recycle.
We are Lions. We bring hope where it's needed, support causes that matter, change lives, change communities, change the world. Visit lionsclubs.org to learn more.
Part-time job, full-time hustle, all-time Shiro to all of us. Now it's time for you, our Shiro, to stretch for the stars. Get free tips to help boost your retirement savings now at aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council.
Hi, I'm Paula Strang, and I support Kingston Community Radio, and so should you.
And we're back. Thank you for being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. It's 8:03 a.m., and it's 52 degrees here in Uptown Kingston, Monday, May 24th. This upcoming portion of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs. Discover the difference of buying local. Sales ongoing at herzogs.com. Now we're going to do the birthdays at about 8:15 today. Okay, so stand by, and we're going to do the birthdays after our guest, who has to leave at about 8:15, and that's just stand by, and we've got a lot of birthdays to go through, and we'll do them at 8:15 rather than 8:05. Welcome back, Dr. Alio.
Thank you. We have Dr. Richard Dentico on the line with us. Are you there, Dr. Dentico?
Yes, I am, Matt. How are you? Good morning.
Good. Thank you for coming on. With us, by the way, is Dr. Bruce Moore. I don't know if you know Dr. Moore. He's a radiologist here. And so he's here sitting with me. He's on after you. But anyhow, tell us a little bit about your background and the group you're with. And I thought maybe, I don't know if you're an anesthesiologist. Tell me what your background is in pain management.
Sure, Ed. Well, thanks again for having me on. I appreciate it. These things are always a lot of fun. So I'm actually a physiatrist. Physical medicine rehabilitation has been my training. I did my residency down at the UMDNJ West Orange campus. So I worked out of the Kessler Institute, is where I did the bulk of my training. Between there and University Hospital in Newark is where I did my training. I did my fellowship under Dr. Gerard Malenga out of, I guess he was out of the Atlantic Health System at that time. I think he's on his own right now in private practice. And I've been for the past 11 years now, I've been up in Dutchess County. It's the Orthopedic Associates of Dutchess County orthopedic practice, and I've been practicing a combination of general physiatry and pain management, with the bulk of my practice being primarily pain management at this point in time.
Huh. I didn't know that you were a physiatrist. So I should know that because you treated me once about a bunch of years ago, very successfully, by the way. That's how I met you. So tell me, what when you talk about pain management, for the listeners, what does that mean?
Right. I guess that's a broad umbrella. So that's a good question to ask, because there's a variety of different pain managements or pain management options that people can be offered, including the more traditional and things that we're trying to stray away from is more medicine management or opioid pain medicine management, and that is still an important aspect of pain management practice, is treating people with medications. However, it's frowned upon, especially in the world that I live in the back pain world and in the more sort of somatic pain world, as opposed to pain management in the end of life care and when we're talking about cancer patients and chronic cancer pain. These are two different realms. I tend not to see the latter of the two. I see more injured patients. And there are a lot of options for patients outside of those treatments that have been more traditional and seem to have gotten us into a little trouble in society overall, maybe more than just a little trouble. But having a massive amount of opioids out in the communities, apparently in hindsight now, was actually a bad idea. So my focus of my treatment is trying to rehab people using more traditional physical medicine approaches through therapies and bracing and more of that approach, and then interventions, injections, corticosteroid injections, ablation procedures, different types of procedures that we can go through. And at the end of the day, patients find themselves in a much better functional spot, less pain and functioning better. And that tries to be the crux of my treatment, is more the functional side. The pain is inhibiting function. So what can I do to improve function, and how can I get rid of the pain that will allow this patient to then function to their capacity.
So when people are listening right now and they want to know, what's an epidural?
Okay, so we're talking about spine pain right now, and so the epidural is a space that exists inside the spinal canal. It's sort of, if you can imagine, a covering or a taut covering over all of your nerves and spinal cord, and that's called your dura. So outside of that covering and inside the bony window of the spinal canal is a space called the epidural space. It's filled with fat cells and blood vessels, and it's the space where people can develop a lot of inflammation around nerves, and that typically comes from the intervertebral disc. Again, we're getting into a lot of anatomy, but there's a piece of soft tissue that lives between the bones. And if you could think of your spinal bones almost as Lego blocks that stack upon each other and fit into each other quite perfectly, and then by having a piece of disc or a piece of soft tissue between these bones, it allows for an immense amount of flexibility. But in some of these areas, there could be some weaknesses, and when those discs develop some type of pathology, whether it's a tear in the disc or the disc herniates out, meaning it pushes out, it gets tears in the fibers, the inner contents of the disc end up in that epidural space, and that's a prime source of pain for a lot of back pain. And so when you talk about an epidural is just whether you're pregnant and you're going through labor or you're having back pain, the epidural space is the space we access to try to provide anesthesia, or in my case, anti-inflammatory medication to reduce that inflammation, and again, hopefully seeing some improvements in overall pain and thereby function.
And how long? I remember I had an epidural one time, and you helped me. And the first time we did it, we did it at a level L2 or L3 it was, and then it wasn't as successful. And then we did it lower at L5. Why would you do that? I mean, in what situation?
Well, again, it's the clinical situation. How do you present? Where does the pain pattern seem to be coming from? Everybody's pain pattern falls into sort of these different buckets, and depending on how you present clinically, we'll try to go back and look at your MRI imaging or imaging of the spine and try to see, well, is there pathology here that makes sense with the clinical presentation? And if it does, that's typically where we start with the procedure. Many people, and again, Dr. Moore will comment on, I'm sure of some radiology stuff, is we feel he'll read a lot of stuff on that MRI and a magnetic resonance imaging, which is a three-dimensional image that's constructed, and it gives you quite a bit of information. But there can be a lot of incidental findings, so to speak, or asymptomatic findings where, there's a disc herniation here, but their clinical symptoms are different. It looks like it'd be coming from the other disc. So it's tough sometimes to decipher between all the pathology you see and then have to match that up with the clinical presentation. So sometimes we'll maybe miss the mark. Maybe be a level or two off, and we won't get that positive response that we're hoping for. And then sometimes you have to go, that's, I guess, the art of medicine a little bit, is finding that right spot and trying to hit the home run for that patient on every encounter.
So we put both the science and the art together, right?
That's always the hope. That's always the goal, correct.
And Dr. Moore, Dr. Moore, how do you interact with Dr. Dentigo in that situation?
Well, our job is basically to describe the anatomy that we see in the spine. He's referring to these discs that protrude, and they protrude and are in contact with neural elements, which causes the pain. Now, we can say that this disc is compressing this nerve or is it adjacent to the nerve, but that doesn't really tell us how much inflammation is taking place in that nerve, and that's really what's causing the pain. It isn't always just the physical compression, it's the contact. So we try to give as much anatomic information about what's going on in the spine and what's happening to the nerves. And then he basically marries that with the clinical presentation and his examination, and he treats accordingly, right?
100% agree with that. The radiologist is the key player in the game here, in a sense, and giving us a comprehensive read on the study. We always look at the studies ourselves, and just to and to have another set of eyes on it. But you fall back on that radiology report. You want to make sure you're not missing anything, and especially sometimes these incidental findings pop up, which is not my expertise. And to have an expert, backing us up to make sure we don't miss anything that can be ominous or serious on those images is vitally important for the overall care of the patient.
Interesting. So, other than the epidural, what other kind of treatment do you do for the nerves? If they have leg pain, that's one instant. But if they have back pain without leg pain, is there a difference?
Right. So typically back pain without leg pain is typically stemming up, in my opinion, from two different areas. Again, we'll go back to the disc. A disc that is just degenerative. It's not causing active inflammation around the nerve. It's not pressing on the nerve. That could be discogenic back pain, meaning axial back pain not radiating down the leg, can be emanating from the disc. Another point that I find that I help people a lot out in is the arthritic condition in the back, and you could have two joints on the posterior part of the spine, like very superficial. I mean, you can almost feel them sometimes on certain patients, but there's joints that line the spine, and they become arthritic. They're synovial joints, meaning they're the same type of joints you'd have in your hand, and about the same size as the joints in some of your hand, in some of your some of the joints in your hand, and they become arthritic. So we could target those. We could target those with, again, same thing, an anti-inflammatory injection into the joint versus blocking the joint, finding the nerve that actually innervates that joint and blocking that nerve. They're quite, on most human beings, they fall in the same anatomical region that we're able to identify in X-ray, and then we're able to guide a needle right close to that nerve and inject a long-acting anesthetic, giving us an idea of how much pain is coming from that joint. So it's a short-lived injection for the patient, but they get a sense of, well, before I had this injection, my pain was an 8 or a 9 out of 10, and for the day after, from the point in time you gave me the injection until whenever the anesthetic wore off, I was relatively pain-free. So that clues me into, okay, this person is suffering from an arthritic condition in their back, and then there are other procedures that we move on to try to provide more long-term benefit, such as like an ablation procedure, where through a needle we cauterize that tiny nerve. That procedure can last the patient anywhere between 12 to 18 months at a time, if successful.
And then what happens after that? Does it reoccur again, or are they pain-free?
No. Sorry. Yeah. So what happens is that we don't really destroy the nerve. We're not cutting the nerve. When you heat up a nerve, it sort of just goes through a physiological process of sort of dying back to the cell body, and then it regenerates right through that same tube. So it'll actually make the connection again. It usually takes about a year to 18 months for that to happen, and once that connection makes it back to the joint again, you might start to feel that same discomfort again, and then we can go right back in and do the same process.
So does one ever sever that nerve or permanently, or just do the ablation?
Yeah, just the ablation. Severing that nerve would require probably a surgical procedure. That typically was called a rhizotomy. They did those back in the day for a lot of. Rhizotomy is more when the ones I'm thinking about are more when they were CP children with a lot of spasticity in the lower limbs. They would sever some nerves to prevent the that neural circuit from developing and to try to cut down some of the spasticity in the lower limbs. But the procedure is safe, and it probably makes more sense just to ablate the nerve than severing the nerves, which I think would require more of a surgical procedure.
Okay, so that's pretty informative. I appreciate that. Back to the spasticity. When you talk about spasticity in somebody with cerebral palsy, that means that they contract and hold, and they hold. Is that what you mean by spasticity?
Correct. Unfortunately, these are neurological conditions where the nervous system is dysfunctioning in a sense that it has the muscle in constant contraction and constant spasm, which makes it difficult for hygiene, ambulation, etc. And that's a special population, the CP population.
Right. Well, I just wanted to go back to the spasticity word itself. That's pretty interesting. So of the treatments you do, we talked about the epidurals and stuff. What else do you do for back pain? Since we're on or do you also treat people who have problem with arthritis in their hands and stuff like that, or just back pain?
Sure. So, I work in a surgical practice. So, there are many cases where are resistant to, interventions that I can offer. And we have a great team of spine surgeons and other surgeons that could definitely help those patients out. But moving on to more conservative treatment, which is the focus of my practice.
Right.
Treating patients without surgery. I do treat peripheral joints. There's a host of different type of non-steroidal medications that we use for arthritis, such as hyaluronic acid injections that we use for the knees and the shoulders. I do some regenerative medicine where we use the patient's own body products. So platelets, one of my favorite procedures is using a platelet-rich plasma graft, which is taking blood draw, about 60 cc's of about 2 ounces of a person's blood, and concentrating the platelets out and getting a very concentrated aliquot of platelets, and then injecting them back into joints and tendons that are arthritic or partially torn or tendinotic, and in the hopes to try to regenerate the tissue, stimulate the cells to heal the areas that are injured, and it seems to work out very, very well for a lot of patients. And it's a very interesting and fun procedure to do.
It sounds that's kind of a nouveau approach in the last 10, 15 years.
Yeah, I would say at least 10 to 15, probably a little bit longer. It was, it first came out, I remember seeing some stuff in like the 70s or the 80s, using it in cardiothoracic surgeries to reduce comorbidities, and after surgery, essentially helping heal, aligning the sternal wounds with the PRP to help it heal. And then more in the early 2000s is when we started to see it used in orthopedics. And you see it a lot. If you look through the sports literature, you'll find that many athletes have opted for it. I know there's a couple of pitchers that have gone for that, for their ulnar collateral ligament in lieu of Tommy John, or able to get through their baseball season and with the anticipation of then doing the surgery at the end of the year. So
is this the I'm sorry, is this the quintessential of stem cell?
Say again, I'm sorry?
Is this the quintessential of stem cell type treatment?
It's along the lines of stem cell type of treatment. Stem cell treatment would actually be harvesting the stem cell, which is called a bone marrow aspirate complex. So you don't really isolate the stem cells out, but you harvest a milieu of cells from the bone marrow. You concentrate them back into the plasma that comes out of the bone marrow also, and you can inject those into joints also. So we've done some of those also.
That's a pretty great stuff you're doing, and I'm sure that the community doesn't necessarily know all the things that you do there. So that's great. I know that you have to run. Would you be willing to come back and talk to us again in the future?
100%, Ed. I appreciate this, and I'm sorry I couldn't get that one thing off my schedule, but I appreciate you guys having me on so much.
Okay, good. Well, take care of your patient, and we'll talk to you again, okay?
All right, Ed. You be well, okay?
Take care. Bye-bye.
Take care.
Bye now.
Bye-bye.
Okay, now just as we discussed, we'll do all the birthdays that we have today. It is birthday time, so thanks to Boyce Dairy Milk House and Kingston Community Radio, we have a number of birthdays to announce. And birthday number 1 is for Monday, May 24th, Susanna Bickett. Love, Marianne, and William Banks Jr. Happy birthday, Susanna Bickett. And please wish a happy birthday to Margaret O'Neill from Mom, Dad, T-Bone, and Trixie. Happy birthday, Margaret O'Neill. And also for Monday, May 24th, happy birthday to Linda Davis from those you served at the Orville Norman Mall Walkers Coffee Klatch. Linda Davis, happy birthday. And Donna Maurer from your friends at the Hurley Pearlers. Happy birthday, Donna Maurer. And also, we wish you a happy 82nd birthday to Barbara Crow. And that is from your friends and family, husband Gordon, children Cheryl, Tom, and Craig, grandchildren Joel, Megan, Seth, and Philip, and great-grandchildren Landon, Alana, and Lucas. Happy birthday, Barbara Craw. And the happy birthday winner for the famous cow pie, May 24th, Margaret O'Neill. Courtesy of Boyce Dairy Milk House and Kingston Community Radio. And we'll do the bell.
Moo.
That was the worst one
I
ever
do
did.
this before. I don't know. It's new to me.
Okay. Now we're back.
Thanks, Dan. I had to go find the bell. So then Tony usually does the moo.
Oh, he does.
Yeah. So I have Dr. Moore with me. Dr. Moore's a radiologist, and he was on earlier with us talking. It seems like Dr. Moore interfaces nicely with both the urologist we had on, and who's a surgeon, and then we had a pain management physician on who's a physiatrist who does different procedures, and he also relies on Dr. Moore for the imaging. So, Dr. Moore, welcome again.
Thank you.
Tell us a little bit. You told us about your background before. Just give us a quick synapse on that again, and what you do, and how long you've been around Kingston.
Since the beginning of time. but more specifically about 45 years. So my background is as a diagnostic radiologist, which is basically somebody who does imaging studies and reads films and so forth. But my specialty really is beyond that. I have a blend of both the imaging expertise and surgical expertise. So I do interventional radiology.
What does that mean?
Well, what that means is back in the 70s and actually late 60s, there was some clever people decided that why don't we use imaging to guide us to do certain procedures instead of just opening somebody's belly, opening somebody's chest, and causing a major intervention. Why don't we use imaging to target whatever we want to get to, and then we can use a needle to get into it.
So do they do the imaging on site? So in other words, so you have some kind of a machine, or X-ray machine, or
Right.
what do you use to zero in?
We can use one of three modalities. We can use just regular fluoroscopy, which is X-ray imaging. We can use CT imaging, and we can use ultrasound. Any of these devices to target the area we want to get to. Now, what are we doing? Several things. Somebody comes in with a lump in their lung. What do? Is it malignant? Is it benign? Well, you need to get tissue to find out what to do with it. So in the past, if I had a nodule in my right upper lobe, I'd go to a chest surgeon. They'd take out my right upper lobe, which is
Pretty major.
quite a disability to lose that. Now what we do is we see something on a CT scan, we see a nodule, and I'll take a patient in, put him under the CT scanner, target the lesion, and then I can pass a needle in through the chest wall, into the lung, and into the nodule, and I get little pieces of tissue. It's like a piece of angel hair pasta, but it's enough to make a diagnosis. And based on that diagnosis, the surgeon knows whether or not it's benign or malignant, if it needs to come out, and the oncologist knows that if it is malignant, what sort of treatment the patient needs.
So it doesn't necessarily mean surgery all the time.
Exactly. It's a way of avoiding surgery, and it's a way of tailoring the surgery so it's the right surgery, instead of just blindly going in.
Well, that's good. And how many cases do you do? Like, is it a week, a day?
It varies. I can do. Well, I do a whole series of interventional procedures. I'll do maybe a dozen cases a week.
So is it always looking for tumors, or is it for other reasons?
No, it isn't always tumors. It's to fix blockages. Okay. Now, blockages, we had Walter Parker here talking about blockages caused by stones in the urinary tract. So I'll put a tube in to decompress the kidney so that the renal function is preserved, the pain is decreased.
So when you say that, do you drain the kidney then?
Yeah, I just drain the kidney. I put a tube
bladder
directly into the kidney, and if a kidney is obstructed, eventually it can become infected. And then it's quite a serious situation. So it helps to prevent infection, and in some cases, if the patient already is infected, I can put a tube in there and drain out all the pus and really.
Oh, cool. So I mean, you can't really do the if somebody had a stone, you don't really remove the stone right away. If they have the infection, you want to take care of the infection first.
Exactly.
Why is that?
Because somebody who's septic and has a serious infection is in jeopardy of dying. So you don't want to do major surgery on somebody who's that ill, unless you have no other choice. And in this case, if we can get the patient in better shape, that's the direction to go.
If somebody has, Do you ever do something with somebody with acute appendicitis? Do you ever look at that, or is that different?
Well, I drain abscesses elsewhere. Somebody who has appendicitis and
Okay.
somebody has appendicitis and it's ruptured, there's an abscess around the appendix, so I can put a tube in there and drain that. So these are the sorts of procedures we do to treat infections.
So there's a variety of things that you can do, obviously.
Oh, yeah.
I'm impressed.
Well, I'm glad to hear that.
I've known Dr. Moore for many, many years. We were on staff together. In those days, we were like the youngest guys in the group.
Mm-hmm.
Remember the old days? We go to a medical staff meeting, everybody wore a tie. Nobody wears a tie anymore.
No more ties.
Well, there are a number of reasons nobody wears a tie, but one of them was that when you lean over a patient when they're ill, you got your tie on and your tie is rubbing up against them. And
the solution there was a bow tie.
A bow tie. I used to wear a bow tie once, but that was a long time ago. Anyhow, that's interesting. What we're going to do is we're going to talk some more. We're going to go on a break in a minute, but to get ready for that, excuse me, I wanted to get some other ideas on in radiology in general. What is the main thrust, and what are the different procedures that radiologists use, other than what we just talked about, including what we just talked about?
Oh boy.
Yeah,
it's a wide open field.
And we can do the whole thing. Are you ready, Dan? Okay, we're going to go on break here in just for a second. Okay, we'll be back.
To be continued.
Thank you, guys. Thank you so much, Dr. Bruce Moore and Dr. Ed Alio. And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. This portion of Kingston Community Radio was brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs, and discover the difference of buying local. Check out their website, herzogs.com, and they have ongoing sales. And a little bit about the weather and forecast for Kingston and the surrounding areas. Today, sun and clouds mixed with a high of 71. Tonight, a few clouds, a low of 49. Tuesday, partly cloudy skies, a high of 77. Tuesday night, partly cloudy, a low near 60. Wednesday, partly cloudy with a 40% chance of afternoon showers or thunderstorms possible, with possible strong gusts of wind also. A high of 86. And we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Your old fridge or freezer has served you well for many years and through many summer holidays and barbecues. But now, it's an inefficient energy hog running up your electric bill. Cash in on Memorial Day appliance sales and upgrade to an Energy Star certified model. Central Hudson will pick up your old refrigerator or freezer, recycle it, and pay you $100. To schedule a pickup, visit centralhudson.com/recycle.
We are Lions. We bring hope where it's needed, support causes that matter, change lives, change communities, change the world. Visit lionsclubs.org to learn more.
Part-time job, full-time hustle, all-time Shiro to all of us. Now it's time for you, our Shiro, to stretch for the stars. Get free tips to help boost your retirement savings now at aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you and support KCR.
And thank you all for supporting KCR. This is Monday, May 24th, and it's 57 degrees now here in Uptown Kingston. And your call-in number is 331-9255. That's your number to call in, 331-9255, to speak with Dr. Ed Alio and Dr. Bruce Moore. And you are... This upcoming portion of Kingston Community Radio is underwritten by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Let's get back to the on-air studio with Dr. Ed Alio.
Thank you. Appreciate that. I have Dr. Bruce Moore with me. He's a radiologist, as I mentioned, and we were just talking about the different things that he does intervention-wise. But I wanted to look at sort of the basics of what radiology is and what the different modalities are in radiology, just in imaging-wise. Mm-hmm. So, it comes to mind that, people hear the word MRI. What does it mean? And then they hear the word CT scan, and then there's the old X-ray. What are the difference between the three? What do they mean?
Well, why don't we start with the simplest first, X-ray. An X-ray is basically an image that's made by X-rays, which are high energy radiation that actually goes through your body. It's created by a tube that emits these X-rays. The X-rays go through your body and they get absorbed by various tissues.
Interesting. I just had this image when I was a kid. It does two things. It says how bizarre people were in the old days, and it says how long I've been around. But we used to go to a shoe store.
Yes.
And you stick your foot into you put your feet into this little cubby hole and it would take an X-ray of your shoe, of your foot.
Mm-hmm.
And,
that's right.
I think they did away with that.
They didn't know any better, and it was a good marketing scheme.
Yeah.
But as a result of that, some people developed thyroid cancer because they did it so much.
That's right.
Yeah, the stray radiation went up to the thyroid and induced cancer, but that takes about 20 years to happen. So getting back to X-rays, the X-rays go through your body. They get absorbed to various extents depending upon the density of the tissue. Bone, being the densest part of your body, absorbs most of the radiation. The lung, which is mostly air, absorbs the least. So you get this gradation of colors, or actually gray, from white to black. And that makes an image. And it used to be that this was a photographic film was exposed to these X-rays, and you had to develop them. But now it's done by solid-state detectors, and it's all done electronically, and it's presented on just a CRT.
So that's the basics.
That's the basics. Okay, then we go up to CT, which uses X-ray also, but it...
what does it mean, CT?
Computed tomography.
Okay.
And tomography means taking slices, and computed means using a computer. So you have this, you make these slices of the body with X-rays, and the computer basically reassembles all these slices so that you can see the body parts in 3 dimensions.
So is it for, the first one, the X-ray was like for bone, looking at bone density, or because it was more dense, and now we got the CT, it does slices. Does it look at bone also, or does it look at soft tissue, or what?
Looks at everything.
What's it best for?
CT, where do I start?
Anywhere.
It visualizes soft tissues. It visualizes bones beautifully. It gives you good spatial relationships between structures, so you can see distances. You can measure them accurately, and I use that in interventional procedures all the time. I know my depth. I know my angle. So CT is an all-around valuable asset. Somebody hits their head. Do they have blood on their brain? Do they have a subdural hematoma? Well, CT will show that right away. Blood will show up as very bright
Versus, it won't show up on an X-ray, obviously.
Won't show up on an X-ray, right?
We talk about MRI. It may not be the same
Yeah.
for that. Because so if a little bit for fluid, a CT would be a good option, maybe.
Yeah, for small lung nodules. There are many lung nodules you just don't see on X-ray because they're too small, but CT is very precise, and you can see and detect early nodules. That's why you have these screening programs for smokers. You have this low dose CT, which basically looks for these early nodules so that you can get cancers while they're curable, as opposed to spread.
And how often is that done? I mean, how often do people do the scanning, to do a sort of like a health situation where you want to make sure? Do physicians say, you're a smoker, we let's do this as a baseline, or do they have to have symptoms?
No, asymptomatic. Screening procedures are for patients who don't have symptoms. You're finding disease early, strategically using different imaging techniques on a periodic basis to look for disease.
I wonder if many smokers knew that. They should be more educated on that area to get a screening. It would definitely save a lot of lives and a lot of lungs.
Absolutely. It's and there are protocols for doing that. One of the early problems was there wasn't insurance money for it. So
as a screening.
Yeah, as a screening too. Yeah.
Now it's
pretty much paid for.
Well, that's cool. So we should educate our listeners on that, especially if you've been smoking for any length of time, obviously, but 10 years or longer.
Yeah.
You might want to get yourself to your physician and say, I'd like to get a screening, a CT of my lung to look for small nodules. I don't think people know that. And maybe we should advertise that somehow.
Yeah,
I think that's a great one.
Because lung cancer is so lethal that if you just remove it early, then you're cured.
Oh, interesting. That's good. Well, let's move on to the MRI.
Okay, so we're getting to much more complex technology. It's magnetic resonance imaging. What you're basically doing is subjecting the patient in a strong magnetic field to radio frequencies. Now, the radio frequencies change the orientation of the hydrogen atom in your body, and hydrogen is in water, and you've got water all over your body. And the radio frequency changes the orientation of these hydrogen atoms, and then when you turn off the radio frequency, the hydrogen atoms go back to their baseline position. And
they give you an image?
They actually give off radio frequency as they're going into the relaxed state, and then you can make an image based on computer algorithms. So it's pretty sophisticated stuff.
Sounds it.
But what it does is MR can give you some functional information about what's going on in the brain, and it's much better at seeing early changes in soft tissues. Uh-huh. So if you have, terrific pain in an arm or a leg or a knee, you can see things on MR that you just can't see on CT, and clearly not on plain X-rays.
Huh, that's pretty good. So I thought that the CT saw smaller nodules in the MRI.
Well, okay, so you're talking about two different things: spatial resolution and contrast resolution. Spatial resolution is the smaller size you can see, and CT is exquisite at doing that. Contrast resolution is differences in the density, and MR is a little more sensitive with that.
That's good. See, I always like, I like the basics for people to understand the basics when we're talking about this stuff, because sometimes we take for granted that everybody understands the difference in these different modalities, and in reality, they don't. And so I think I always like the basics on every aspect of,
Sure.
of medicine. And
Yeah, there's a lot of techno talk that
Yeah.
just goes over people's heads, and it just
break it down to something simple.
yeah. Now the last modality is ultrasound.
Yeah.
and
I'll go
that's
to that one.
that's particularly nice because it's inexpensive, it's non-invasive. There's no radiation involved, at least X-radiation, and it's portable, and it's got lots of
Quick.
uses. Yeah,
It's quick.
Yeah.
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 Lay down and look at somebody's bladder, or
Yeah, look at somebody's bladder, look at somebody's heart, see how the heart is pumping. You can see the ejection of blood, and you calculate that. So it's got many, many, many uses. And of course, in obstetrics and gynecology, it's
blood clots.
yeah, blood clots. Yeah, people who have sore legs or suddenly they develop a pain in their calf, you can do an ultrasound, you can see the clot. And the reason you want to see the clot is because you want to treat it, because clots, if left untreated, can be, some of them can be lethal. They go to your lung. So ultrasound is extraordinarily valuable.
So we have like 4 modalities then,
Mm-hmm.
in essence.
Oh, yeah. Yeah.
And then the extra thing what you do is
I sort of mix them around and do my interventions, and hopefully we do some good.
when you mix them around, what do you find? Well, not what do you find? That's the wrong word. What do you use most often? Ultrasound versus
Well, for biopsies, I use I use CT for tumor biopsies. For thyroids, I use ultrasound to do the ultrasound guided thyroid biopsies. And MR, you can use MR for intervention, but it's a lot more complex because you can't have anything there that's ferromagnetic.
right.
Because it'll get sucked right into the magnet, and then you're in trouble.
Well, back to the MR. When people, we have all these implants in our bodies these days.
Oh,
so
yeah.
you have to make sure that it's not metal oriented. Whether even like a simple thing like a stapendectomy, where they used to put a wire in there to connect the 2 bones and that go into your ear, your middle ear, and that would be pretty.
That would be disastrous.
Yeah. They would just pull. And what's when people have MRIs, they get into this tube and they hear this banging sound, what's that all about?
That's the radio frequency being turned on and off, because there are these coils, and the radio frequency goes through the coils, and it actually makes a sound. So that's the bum 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 bum, and the different sequences use different tempos for these sounds. So you'll hear very rapid sequences. You'll hear slower ones, but that's the turning on and turning off of the radio frequency.
So a little dance recital they're going on.
Well, it can be a problem if people start tapping their toes to the to the beat.
Stop moving.
Exactly.
You're messing up. When they do move, you can see that they're
Oh, yeah.
distorting the image,
Oh,
right?
absolutely. Yeah, they have to stay really still.
And those who are a little claustrophobic.
There are ways of dealing with that. Most of it can be just reassurance and even hand holding. You can have somebody in the room holding a hand. And then if it's really difficult to control, you can use drugs.
Well, some people legitimately have a little claustrophobic problems, but generally most people tolerate it.
Yeah.
And they do well. That's interesting. Let's go back to the stuff that you do in the intervention. Are there many people in your program who do what you do, or?
There are a couple. There's some things I do. I'm the only one in the county that does them.
Is that right?
Yeah. Radio frequency ablation. Just like Dr. Dentico, he uses ablation to basically interrupt nerve function and pain. But I use a much more powerful radio frequency ablation, which basically destroys tumor tissue.
Yeah.
So if somebody who's not really an operative candidate, they have a tumor in their liver, let's say, I can put a probe in there and basically cook cook the tumor.
And are you able to do enough of the?
Well, you position the probe so that you have a good overlap, and you get into normal tissue as well, so that you have a clean margin, essentially. Yeah.
The margins are important. By margins, we're saying that
where the tumor transitions to normal tissue.
So you take a little bit of normal tissue to
Exactly.
do that, so that you don't leave anything behind.
Right. Exactly.
Cool. That's interesting. And so when people have radiation, that's different from what we just said.
Yeah, radiation is, that's a whole specialty. It's radiotherapy. That's using really high energy X-rays and various other atomic, subatomic particles, protons and whatnot, to destroy tumor tissue.
Well, I'll tell you, are we up for a break? Can we take a quick break here for a second?
We're almost to the end of the show. The show is over at 9, and
Okay.
but we can if your schedule requires it, we can end a little bit early
No,
today.
we don't need to end. I just needed a break. I had to find something.
Oh, okay, all right,
Okay.
yes.
So
And there was a comment that you were making in regard to audiology a little earlier, and I had to take a call, so I didn't get a chance to be with you. By the way, there was there were a couple listeners that would like to get a hold of you, and would like to know what your contacts are in order to be able to reach you as an audiologist.
Sure. I can give you my number. I'll give you my cell number, and they can, if I can't solve the problem, I'll direct them. My number is 845-430-9080. You can write that down, Dan, for the future.
Okay.
But what's the question you had?
430-9080, right?
Yeah. And you said
Okay,
you had a question?
that's always good. No, there was something we were talking about in regard to pressure differences between the inner ear, the middle ear, and the outside air pressure. We were talking about that.
Valsalva? You mean like the Valsalva eustachian tube thing?
I think that was what you were going to, and I took a call and I couldn't.
Well, I think we were just talking about, when you have pressure differences, your ear responds to that. Just like other parts of your body respond to pressure. There's, inside your body, there's pressure. But within your ear, the eardrum is not the block. I mean, it doesn't mean that what's out here doesn't get inside to middle ear. It's the eustachian tube, which is from your throat, if you will, your pharynx, to your middle ear, which is behind your eardrum, and that kind of equalizes it. So when you're coming down from an airplane, for example, as you come down, the pressure is higher on your eardrum on the outside, and there's less air in your middle ear space.
Yep.
So the only way to clear that is to hold your nose, because now there's air in your mouth, and you blow, and that forces up the eustachian tube, and that equalizes the pressure.
Valsalva.
And it will pop. I think at the
exactly.
time, Marmo was talking about pressure.
Absolutely.
He felt pressure and popping when he did skydiving. When he did skydiving, he wasn't thinking about it then. He was just coming up and down in an airplane. But anyhow,
usually regulates.
Does that help you a little bit, Dan? Understand that?
Of course, yes. There was something else we were getting into that was a little bit more in-depth, but
you think
no
about
problem.
You get back to me. Meanwhile, let's get back to Dr. Moore.
Absolutely.
He's going to talk. The pressure he talks about is a little different. We were just talking about Dr. Moore had to go and look outside and take a quick call. He took care of that. He's back. So we're talking about pressure differences between one side of the eardrum to the other.
Yeah.
Do you have any pressure differences in your program? Just kidding.
My pressure is different.
Well, Dr. Moore also, interestingly enough, Dr. Moore has a lot of experience within his family. He has a son that's also an audiologist like myself.
Yeah. It was fascinating. He got into audiology because he had fluid in his middle ear, and his language development was poor. He was about 2.5, and he just wasn't vocalizing the way he should. So I took him to Dr. Alio, who basically diagnosed the fluid, and he said, "Your son needs tubes." And at that time, tubes in the ear were not in vogue. A lot of the ENTs basically said, no, we're not going to do that. So we found an ENT who did it, and within days he started speaking.
It's amazing. In the old days, the ENT, ear, nose, and throat doctors were the surgeons, and the pediatricians would always see the kid. And there was this old research that said there's no difference between tubes and whether you do tubes and or a TNA, a tonsil and adenoid. So the surgeons, after the fact, they started doing more tubes, but they didn't do TNAs. And of course, as soon as the tube came out, the problem was the tonsil or the adenoid, and the ear problem came back. So this running debate continues today. This is like 40 years later, and they still have this problem. Many times, tubes work very well. You put a tube in an eardrum and it aerates it, but it doesn't solve the problem. Mm-hmm. But it does solve our problem. I shouldn't say that. So it works pretty well. So yeah, that's right. So his son's an audiologist, and we all have hearing loss as we get older. Also.
Oh, tell me about it.
What's that mean?
That means I've been wearing hearing aids for the past 5 years.
Oh. Do they work?
They do. They do. I can hear little birds outside in the morning.
Yeah. It's amazing what people say they hear. They go like the katydids, they go like, I thought those things went away. I haven't heard that in years, and they're still here, And, so it's, one of the most dramatic things that ever happened to me. I think I mentioned it before. If not, I'll do it again. I had this young girl. She was like 7 years old, and she never wore hearing aids. And she had a problem it was a nerve problem, nerve deafness we call it, or sensory neural hearing loss. And we put hearing aids on her, and the first thing she said, she turned the water on, the faucet on, and she heard the faucet. She turned to her father and said, "I didn't know water made sound." Wow. And my brother said the same thing to me, that he forgot that when you flush the toilet or turn the faucet on, that there's a sound there. So it's pretty amazing, the things we take for granted.
Anyway, oh, absolutely.
Yeah. So let's get back to you.
Okay.
What's left here?
So we were talking about what else I do, or
yeah, no. What else? In the scheme of things. First of all, how big is your practice? How many people are in it? And is it still over at the hospital or outside the hospital yet, or what?
Well, we've got, let's see, 1, 2, 3, 4, 5, 6 in our practice. And we work in the hospital, in the Health Alliance Hospital, and we have river radiology. And I was actually the founding member of river radiology, so it's been a while. And those are the sites of practice.
Well, I mean, in your practice, I know that some of them specialize in radioneurology or neuroradiology.
Neuroradiology, yeah. We have a neuroradiologist, board certified.
And what other aspects and what other specialties do you have?
Well, we have fellowship-trained nuclear physicians. Nuclear medicine is using radioisotopes for diagnostic purposes primarily. We also do treat hyperthyroidism with radiation. And let's see.
The isotopes, do they insert those? How does that work? What is that about?
It depends. For what? They're injected mostly. To treat hyperthyroidism, it's actually an iodine capsule that you swallow. And that iodine gets picked up by the thyroid because the thyroid uses iodine to make thyroxine. Mm-hmm. So the thyroid is always scrounging around for iodine, and you give them radioactive iodine, and that's an isotope that has a short a short distance where it destroys the tissue, as opposed to a very long distance. So it gets concentrated in the thyroid, and it destroys thyroid tissue, and the amount of thyroxine you produce decreases because the number of cells producing the thyroxine have died off. So that controls hyperthyroidism.
So do they also, is your practice, or the guys in your practice, do they use the radioisotopes to put into a tumor as a treatment?
No, that would be a radiotherapist doing it. So there's a little bit of crossover, but not much.
Oh, interesting. I mean, again, people don't always understand the total scheme or depth of a person's practice. Like in your practice, you have 6 or 7 different people who specialize in different areas. Dr. Dentigo has the same thing going on with the orthopedic guys. You have hand surgeons and specialize just in hands only. We've become, I wonder, does that make a difference as opposed to a generalist?
Well, as information gets, as we learn more, it becomes incumbent upon us to basically specialize, at least partially specialize, so that we can have an expertise.
Well, I notice, you specialize in different areas, but you still have a broad knowledge base of everything that's going on.
Well, my feeling is a physician is a physician is a physician. And then on top of that, you specialize. So, even, you can't put the blinders on and just say, oh, this is all I just do. Yeah. Then you're not a physician. You're basically a super specialist, and then you'll miss things.
Good for you. You like that, Dan?
That's a great seg. That's a great outro.
Well, I want to
wonderful outro.
We had a great day today. I want to thank Dr. Moore again for coming in. Maybe he'll come back and visit with us again.
Sure.
And we'll see what's going on. Okay, Dan?
Okay. Thank you so much,
care,
folks. Okay. Bye. And thank you very, very, very much, Dr. Bruce Moore, radiologist and co-founder of River Radiology. It's now 9:00 a.m., and you are with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. And thank you for being with us today at Kingston Community Radio, and with our live streaming on mykcr.org. Monday, May 24th, about 57 degrees. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, locations near you. And until tomorrow at 7 a.m., we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you back to Magic 92.5.